The wrong move, in a shattered body, feels obvious. Take the metal out, close the wound, clean up the damage, save the man. That sounds like common sense. But by the middle of World War II, one of the most important lessons in battlefield surgery was almost the opposite. Sometimes, the safest thing a surgeon could do was not to dig deeper, not to chase every fragment, not to close the wound neatly. Sometimes, the body survived because the wound was left disturbingly unfinished. And that is the strange core of this story, because this is not only about blood and shrapnel. It is about how war forced medicine to stop treating a wound like a simple hole in the body and start treating it like a system full of dead tissue, hidden contamination, crushed muscle, trapped pressure, and metal that could stay where it was longer than a surgeon safely could. By the end, the surprising part is not that fragments were sometimes left inside people. The surprising part is why that could be the smarter choice. A shrapnel wound looks simple when you imagine it from a distance. A piece of metal goes in, it tears something, it stops. Then, a doctor removes it. Real battlefield wounds were nothing like that. Explosions did not make clean injuries. They drove irregular fragments through clothing, leather, mud, skin, muscle, and bone. And what mattered was not only what entered the body, it was what the body looked like after all that energy arrived. That was the brutal lesson surgeons kept learning. The visible hole could lie. A small opening could hide a much larger zone of damage underneath. Muscle could be dead or dying without looking completely destroyed. Blood supply could be compromised far beyond the visible track. And bacteria did not need some dramatic entrance. They only needed darkness, dead tissue, and time. So if you picture wartime surgery as a race to fish out the metal, you are already looking at the wound the wrong way. The fragment was real, but it was not always the main problem. The first part of this lesson had been learned earlier, in the First World War. Surgeons had already seen what happened when mangled tissue and contamination were left inside the body. But in World War II, that hard lesson became more organized, more systematic, more disciplined. Surgeons became more committed to debridement, cutting away dead and dying tissue. And they became more careful about delayed closure. That meant something very counterintuitive. You did not always close the wound after the first operation. You opened it properly. You removed what could rot. You cleaned what you could reach. You created a path for drainage, and then you waited. To an outsider, that could look rough, even primitive. But it was not primitive. It was an admission that the real danger in the wound was often not the dramatic piece of metal. It was tissue that had already lost its blood supply. Tissue that was turning into fuel for infection. And once surgeons understood that, the logic of the whole wound changed. This is where the story gets uncomfortable. The piece of steel feels like the villain. It is visible. It is tangible. It is the object you can hold up and blame. But the more dangerous threat was often biological. Crushed muscle, disrupted circulation, deep contamination, a pocket inside the body where bacteria could thrive. That is why surgeons could sometimes leave a fragment in place, especially if it was deep, hard to reach, or sitting in a place where more exploration would cause more destruction. Going after every last piece of metal could mean cutting through more muscle, causing more bleeding, lengthening the procedure, worsening the damage the patient was already trying to survive. So the logic became brutally practical. Remove what is accessible and dangerous. Remove what is dead. Do not create a larger graveyard inside the body just to satisfy the eye. That sounds cold, but it makes more sense when you remember where these decisions were happening. Not in calm, modern hospitals with endless time and imaging, but in war. War compresses medicine into survival logic. Mass casualties, transport delays, shock, mud, cold, exhausted teams, limited supplies, and wounded men arriving in waves. Under those conditions, every surgical decision had a cost. Which wounds had to be opened wider? Which tissue could still live? Which fragments mattered? Which procedures cost more life than they saved? Those are not elegant questions. They are survival questions. And World War II forced medicine to answer them at scale. That is why the idea of a dirty trick is more interesting than it sounds. The trick was not dirt itself. The trick was that dirty-looking surgery could lead to a cleaner outcome than neat-looking surgery. A wound that looked more brutal after the first operation could actually have a better future. A wound left open could be safer than one closed too early. A fragment left in place could be less dangerous than the damage caused by chasing it. That is the paradox at the center of the whole story, and it works because it violates instinct. Most people think healing means closure. Sew it up, restore the shape, make the body look whole again. But trauma does not obey the aesthetics of healing. It obeys function, drainage, blood supply, tissue viability, time. War surgery forced that truth into the open. And then antibiotics arrived, with just enough power to save many lives, but not enough power to replace good surgery. That matters. Penicillin became one of the heroic symbols of the war, and rightly so. But the wartime lesson was not that antibiotics had solved the dirty wound. The lesson was that antibiotics worked best when the wound had already been managed intelligently. Debridement still mattered. Delay still mattered. Judgment still mattered. Medicine did not defeat the filthy wound by becoming magically cleaner overnight. It did it by understanding what the wound really was. Not a simple channel with a piece of metal inside, but a living tissue problem with infection, blood supply, pressure, and time all fighting at once. And that logic did not die with the war. Modern trauma care still carries versions of it. Retained metallic fragments are not automatically hunted down at all costs. Deep, soft tissue fragments may be left in place when removing them would cause more damage, and when they are not creating an immediate, specific threat. That is a profound shift in mindset. It means the body is not treated like a broken machine full of loose debris that must all be vacuumed out. It is treated like living tissue under constraints. Every intervention has a cost. Every extra cut changes the biology of survival. And once you see that, the emotional grammar of the wound changes too. The horror is still there, but the logic becomes clearer. Sometimes there was no perfect repair, only a less fatal mistake. That, more than almost anything, is what modern war did to surgery. It humbled it. It forced doctors to admit that more action was not always better action. Sometimes restraint was not passivity. Sometimes restraint was skill. There is a bigger story hiding inside that restraint. War does not only create new weapons, it creates new ways of seeing the body. A body can become, very quickly, a blood loss problem, an infection problem, a transport problem, a salvage problem. And in that process, medicine becomes both more effective and more unsentimental. That is one of the uncomfortable truths behind medical progress in war. Some advances come from compassion under pressure. Some come from repetition. Some come from terrible numbers that make comparison unavoidable. What works survives. What feels right but kills people gets abandoned. And that is exactly why the obvious idea about shrapnel lost some of its authority. Do not trust the small entrance wound. Do not trust clean edges. Do not trust the urge to make the body look finished too soon. And do not assume the metal is the thing most likely to kill. Sometimes the deadliest part of the wound is the tissue that is no longer really alive. Sometimes it is the infection waiting for a sealed space. And that is why this story matters beyond military history. It is really a story about appearance versus function, about the dramatic cause and the consequential mechanism. We are drawn to the obvious object, the bullet, the fragment, the visible damage, the thing we can point to. But systems fail in quieter places, in circulation, in contamination, in pressure, in delay, in the gap between what looks repaired and what is actually recoverable. That is why the legacy of some of the filthiest wounds of the 20th century is not only better battlefield care, it is a deeper medical respect for restraint, not doing the dramatic thing, not chasing every visible problem, not confusing intervention with wisdom. In that sense, World War II did not simply teach surgeons how to remove damage. It taught them how to recognize when more cutting was just another form of harm. So no, the dirtiest part of the wound was not always the metal, and the deadliest mistake was not always leaving something behind. Sometimes the smarter choice looked unfinished. Sometimes survival looked ugly. Sometimes the wound that looked worse at first had a better chance of healing. And sometimes the body was saved not by taking more out, but by understanding what actually had to go. That is the deeper twist here. A war famous for destruction also helped teach a brutal kind of medical restraint. Not because restraint was gentle, but because the body could not afford the wrong kind of help. If you like hidden histories where common sense breaks first and a deeper logic takes its place, subscribe for more.